Hi, welcome to another episode of QD Clinics by Room Now. I'm David Liew from Melbourne, Australia, and today I want to tell you a little bit about a patient I saw in clinic yesterday with checkpoint inhibitor induced inflammatory arthritis and what that might tell us about rheumatoid arthritis, especially given some of the therapeutic trials that have come through in recent times. So yesterday I saw a 78-year-old lady who has melanoma, has stage 3 melanoma, and has been receiving nivolumab as an adjuvant therapy. So nivolumab is a PD-1 inhibitor. It's a checkpoint. A PD-1 is a checkpoint, as I think many people have come to know over the course of time. This is a checkpoint that when we block it, we can potentially unleash inflammation against a tumor, especially a tumor like melanoma, and get great outcomes in cancer. Of course, this was the basis of a Nobel Prize in medicine and has really revolutionized a lot of different cancers, especially melanoma, but many other tumor streams as well. Anyway, this lady on her second cycle of adjuvant nivolumab, so she gets them every 4 weeks, had within the next day after the nivolumab developed what in many other settings would look a lot like rheumatoid arthritis. So she had a small joint polyarticular inflammatory arthritis, woke up with profound early morning stiffness, swelling right across the MCPs, PIPs as well, wrists, all the attributes that one might associate with rheumatoid arthritis. Now, is this rheumatoid arthritis or not? It's a very good question. First of all, to say this has clearly been induced by a drug. And really, if you're looking at that temporal correlation, it's very clearly associated. Not all checkpoint inhibitor induced inflammatory arthritis is so closely temporally correlated, and not all of it looks so closely like rheumatoid arthritis. And we do know that immune checkpoint inhibitor inflammatory arthritis, an irAE, is a distinct entity in of itself. There are different characteristics that mean you can't really lump it in the same category with RA for clinical purposes. But what we can see is that these type of phenomena really have many similar characteristics to rheumatoid arthritis. And then there are other ones that resemble polymyalgia rheumatica, that resemble myositis, that resemble Sjogren's in terms of sicker symptoms. And maybe potentially we can learn a whole lot from these immune-related adverse events from nivolumab and other PD-1 inhibitors and other PD-L1 inhibitors, other checkpoint inhibitors. All of the adverse events that these are creating, we could learn a lot about the classical autoimmune diseases that they resemble. We also see, of course, that when we treat patients with pre-existing autoimmune disease, so with patients who already have rheumatoid arthritis, or already have other rheumatic inflammatory conditions, that we see them flare often, and maybe that can teach us a little bit about flares as well. So this idea that maybe we can learn from the immune-related adverse event is a really interesting idea, that we can learn things that might give us insights about classical autoimmune disease, especially when there's still plenty that we'd like to know about many of those diseases, and still plenty we'd like to know about rheumatoid arthritis flares. So within the cancer world, we know that there are some widespread technologies that we'd like to adopt more widely in rheumatology. We know that we can learn a lot from this induced inflammatory arthritis, what is essentially could be argued to be induced rheumatoid arthritis, but really is something very similar, but something we can learn a lot about rheumatoid arthritis from. When you've got essentially a human model of an induced inflammatory arthritis like this, it really raises a question, could we target something like PD-1 therapeutically? And what we've seen recently is a phase 2A trial published in the New England Journal of Medicine of a PD-1 agonist in the form of peresolimab. And really, I think what we got excited by from that is particularly the patients who were inadequate responders to another biologic DMARD. We saw that these patients actually did really well on peresolimab versus placebo, which is not the opposite of what you usually see. It's not what you expect to see. Of course, the question comes about, if we are going one way to get rid of cancer, could going the other way be of concern? So is safety an issue? Well, we didn't see any episodes in the trial, but these short randomized controlled trials are clearly, with smallish numbers, really are clearly not designed to pick up on those safety signals. What we can take some consolation from, perhaps, is the fact that we already have agonists at checkpoints, which don't seem to lead to an increased rate of cancer. There are some important differences between those checkpoints, but that's true nevertheless. In the form of the CTLA-4 agonist, abatacept, we haven't seen increased rates of cancer when everything's washed out with abatacept in real-world data. And I think we get a lot of reassurance from that. Of course, that doesn't necessarily directly translate to a PD-1 agonist. It certainly does give us encouragement. But really, I think one thing that should give us reassurance is this idea that maybe if we can hit a homeostasis, that we can hit the right equilibrium between unleashing inflammation and retracting it back by inhibiting checkpoints, then maybe we can get really good therapeutic outcomes for our patients without putting them at undue safety. I think there's a lot more to see in this space. It's a really exciting space to have potentially seen an example in the clinic and knowing that this may well lead through astute clinical observation and then targeting the appropriate therapeutic targets, we might well get new therapeutics for rheumatoid arthritis for this. For plenty more in the rheumatoid arthritis campaign this month at RheumNow, head on down to the website, head on down to our social media channels. See you there.